landscape in C3G. With that, it is my humble honor to introduce Dr. Cavanaugh, who is a clinical nephrologist specializing in glomerular disease at the Cleveland Clinic in Cleveland, Ohio, where he has ongoing involvement in clinical trials, education, clinical research. He attended medical school at the Heritage College of Osteopathic Medicine at Ohio University and internal medicine training at the University of Louisville before pursuing a nephrology fellowship at Yale University. I'd like to invite Dr. Cavanaugh to the presentation, and you should be able to just scroll through here. Thank you.
All right.
To learn more.
Okay.
Yes.
Well, yeah, so good.
Back to you.
So what I'll talk about is, as Cecily said, we'll just go over the sort of history and terminology, which can be a little confusing when it comes to C3 and MPGN. How has it damaged kidneys, the innovations that help us understand that, genetic testing, and then some of the targeted therapies we'll talk a little bit more about. So an anatomy lesson, I know, right? Hang on. Yep. No, it doesn't show. So in the middle panel here, this is a 3D image of a glomerulus. About 1 million of those per kidney. And as we were sort of talking throughout the day, this is the filter portion of the kidney. And so how do we diagnose C3 or MPGN? It requires this. We have to have a slice through the glomerulus that is represented by this 2D image here. And it's not important right now that you understand all those little intricacies, but the point is this sort of image is what is required to make the diagnosis. So when you get your kidney biopsy and you send it to the pathologist is going to look at your kidney in sort of 3 respects. With a light microscope and some staining there, and this is literally just the same image, just stained. Then they're going to use immunofluorescence, which is a way we use antibodies to bind to the kidney and light up in certain places. And that sort of pattern of light tells us what's going on. And then in more advanced, we get very, very close images, very microscopically intense to get down to the nitty-gritty of the anatomy in great, great detail. So this is important to understand the anatomy and where we come from the pathologist or the doctor that's going to look at your kidney under the microscope, why the name is the way it is. So what is C3 glomerulopathy? Again, to the pathologist, this is going to be a kidney that has a whole lot of complement deposition in it, arm of the immune system. We'll use terms like complementopathy, or in a way, this is an autoimmune disease most of the time. It's just one we don't talk a lot about. We talk a lot about antibodies in immune systems, but not necessarily complement, which is a different arm of the immune system. To the nephrologist, it's a rare cause of proteinuria, kidney failure, and low complement levels. So, I mean, kidney disease is not uncommon. Glomerulopathies or glomerular disease is rare. And then you're talking about C3, and it's ultra rare. That's the term we use for it. I mean, to say 1 in a million isn't doing it justice. So to the patient, what does that mean? It really isn't necessarily specific. This can just be a cause of swelling and high blood pressure and reduced kidney function. Oftentimes there's not much more unique about it than that from your perspective of what you're feeling, despite all of this very interesting things going on in your kidney. So the term you may have been told of what we were taught in medical school and still to this day is MPGN, or membranoproliferative glomerulonephritis. We don't like saying it either. We don't say it's a mouthful and nobody knows what the hell you're saying. So we just say MPGN. And where did that start? So history and innovation. You give me a history topic, I'm going to tell you about the history. We'll go back to Richard Bright in the 1800s. So this is kind of where this story begins of glomerulonephritis. And this was discovered because he looked at urine and it had some coagulable proteins in it that didn't make any sense. These people were all swollen and they died of kidney failure, seemingly. And that was about the extent of it. That's where the first classification came in. Fast forward about 120 years or so, one of the first trials for membranoproliferative glomerulonephritis. This is from 1963. And what I have here highlighted in red is the membranous proliferative. And how did we make that diagnosis? Well, again, we sort of just looked at your kidney on a biopsy, and you can see all these sort of black dots here around the filter of the kidney. And that's just too many black dots. That means proliferation. Proliferation of membranoproliferative. Proliferation just means too many inflammatory cells, or too many cells reacting. And that's about as simple as it gets. In this study, they actually compared it to membranous without the proliferative, proliferative without the membranous, sclerosing and minimal change. And this was the extent of how we classified glomerular disease back then. That was as deep as it got. This was 11 patients, anywhere from 4 to 41 years of age for MPGN. And they gave them all steroids, and 40% of them responded. And that was the extent of the ability to do clinical trials for MPGN. It was later discovered in the later 60s, early 70s that these were sometimes idiopathic. We couldn't identify the why. And some of them had low complement levels in the blood. And so the terminology started to shift at that point. So what is complement? This is a very hard topic to explain to patients because there's no tangible thing. We don't talk about it a lot. It's not a mainstream conversation. We don't really know how to help you understand tangibly what it is. So to take a step back to appreciate how complex the immune system is, there are 3 sort of arms of the immune system that I'll talk about, and there's more than that, but for the sense of this talk. So there's classical, and that would be immunoglobulin. So in that situation, when you make antibodies to a virus or bacteria, this arm of the complement immune system finds that, and that triggers inflammation in this system. There's something called the lectin pathway, and that is an arm of the immune system that is searching and seeking out constantly in your blood to find a sugar moiety or some foreign invader based on the type of invasion and the structure of their wall, and which triggers autoimmune disease or inflammatory reaction, rather. And then there's what we're talking about, which is the alternative complement cascade. And the best way I can describe this is if there's a bacteria that's getting in, you need a first-line defense. You can't just magically make an antibody that quick to a bacteria you've never seen before. And so there has to be a system in which to protect you immediately, or like the pawns in chess. They have to be there. So alternative complement cascade is a cascade of proteins that signal inflammation. And bacteria often trigger this. The analogy is that we use a lot is a dripping faucet. It's always on. It's always constantly surveilling. It's always trying to cause inflammation in your body at all times. That's the natural state. In fact, this is probably the oldest form of immune system you have. We actually date it back 600 million years ago, before vertebrates even. This is the type of immune system they had. It's ancient. But it's always on, dripping like a faucet, trying to cause inflammation for some foreign invader. Luckily, we have things that prevent that inflammation from progressing. That would be factor H and factor I. It's not important that you know these factors in and out. Just know there are brakes to the system. And if those brakes fail, then we have inflammation. So if you have a constantly dripping faucet of inflammation through the alternative complement pathway, if that amplifies and it hits this amplification loop, which is a series of proteins that turn up things, I liken that to this water wheel. You have a dripping faucet, but now it gets things turning, and you have inflammation that's sort of going out of control for the sake of destroying whatever invader was there. And that's the point of this, is that once you turn on this C3 amplification loop, what you have is inflammatory cells like C3A, opsonization to kill the invading microbes for C3b, cell wall lysis through this bottom pathway here, C5b9, or membrane attack complex. So I don't need you to necessarily know every single detail about this inflammatory cascade, but just know that there are many ways in which the alternative complement pathway damages microbes, calls immune cells to attack microbes, The problem is, if this system gets turned on and it doesn't get turned off, this damages kidneys. And that's what C3 and MPGN ultimately results. So that's another way. I'll talk a little bit more about the terminal complement pathway, which is this C5b9 end of the cascade. And it really literally punches holes in the cells, both bacteria and our own. And it just really reminded me. I always thought someone must have really enjoyed Mario, because that's all I see there. All right. So if we're going to talk about MPGN and how did we get from MPGN to C3G, and are we still there, and what do I have or what does my patient have? So originally, and this was over 10 years ago before this terminology changed, we had MPGN type 1, 2, and 3. And what does that mean? In truth, it's just a pattern. It's just a pattern that the pathologist saw on a special type of slide called electron microscopy from your biopsy, where they saw these little dark stains in certain places of the kidney, and that's in the arrows here. So if there were one place over another, that gave you a different type. So it's all just about patterns. If your staining was here on the outside of the membrane, that's one type. If it's outside and inside, that's another type. If it has this nice long ribbon of darkness along the basement membrane of the kidney, that becomes dense deposit disease, just another type. And you can imagine that, okay, great, you want to make different types, and that's how we categorize things, and that's great, but what does that really tell you about what's going on? The truth is nothing. It doesn't tell you why, it doesn't tell you how, it doesn't give you an idea of treatment. It's just a way to categorize patients to better understand them. So the next step was actually taking these classification of 1, 2, and 3, and when you stained the kidney with the immunofluorescence, sometimes that C3 that I was showing you, part of the amplification loop on the one slide, would light up. And sometimes it didn't light up very much. And so when you're staining for immunoglobulins or complement, the immunofluorescence will show that in certain degrees. What was appreciated was that sometimes this type 1 had a lot of C3 but not much of the immunoglobulin. Sometimes type 3 had a lot of C3 but not much immunoglobulin. But in certain situations, only C3 lit up without immunoglobulin. Said another way, sometimes alternative complement was the thing that was staining. Sometimes it was just antibodies. Sometimes it was both. That means that this categorization didn't really help you. It didn't help you understand which was which. It was just more caveats in the system of categorization. So what is good then if MPGN has types and so much overlap? Well, we realized 10, 15 years ago this really wasn't helpful. It wasn't helpful that we had so much overlap in these systems of categorization. So a leap was taken, or a big significant step forward was taken with pathologists at Columbia and others, in which, all right, let's just bag the old categorization system and say, if you see C3G, that just means that C3 is the dominant thing staining, period, done. Everything else becomes MPGN. And what they did in this study was they basically saw that if there was dominant C3, what they would call 2 orders of magnitude, meaning there may be a little bit of immunoglobulin staining, the other part of the immune system, but if it's mostly C3, that's C3G. And that allowed us to get to this sort of categorization. So this is the old classification. Like I said, all these patterns on these very detailed slides where dark staining here, dark staining there, what does that mean? All right, we'll break it down into just the immunofluorescence type pattern. It's just C3, not a whole lot of C3. How did we distinguish those things? The modern classification now becomes, you have C3G. That just means you have a lot of immunofluorescence for this C3G protein. And the other ones are now MPGN if they don't. So it's really 2 pathways instead of 3 with some caveats. I know that's a lot, and I know that can be really confusing, and I know there's a lot of terms you had to learn just to understand this slide. But the point is that now we're using immunofluorescence. which uses antibodies to bind to certain proteins that are in the kidney. When they light up for just C3, that's C3. If they light up for C3 and immunoglobulins, and they have a certain pattern, that's more MPGN. Why do we care? Well, we care because if you have immunoglobulins and that C3 lighting up, that can be caused by a whole host of things that are sometimes reversible and treatable way beyond just C3. So certain infections can do this to the kidney: hepatitis, HIV, malaria, autoimmune disease like lupus. Usually these are adults or older patients, they can have monoclonal gammopathies, or another way to think about that is leukemias or lymphomas or even multiple myeloma. You can have liver disease, you can have cirrhosis, you can have sarcoidosis, all these other strange diseases that can give you this sort of pattern. And that's relevant because those things are treated. Those things are treated very differently than C3G a lot of times. So you wouldn't want to give someone with an infection immunosuppression just because you saw it on a slide.
So, Corey, or Dr. Cavanaugh,
Of course, fine.
sorry. So I see, if I'm understanding this correctly, I see MPGN is kind of like secondary because you want to treat what's causing that versus C3 is more idiopathic?
Yeah,
Okay.
well said. So MPGN, there's a debate ongoing that there's always a cause of MPGN. Some people don't think there's idiopathic or just MPGN from what you were born with. But yeah, if you see MPGN and it's not C3, you better go to this slide, because this is really the point, is if you have an MPGN pattern, and that was what we identified in the 60s, all these cells in the filter, too much, causing nephrotic syndrome or whatever. If that's the pattern, then you go to your immunofluorescence staining and you see immunoglobulins but no C3, you better go down this pathway of finding if they have some blood cancer, if they have autoimmune disease or an infection causing this. That's the point. If you do not have immunoglobulins and you're just seeing that C3 staining light up, that was literally the first slide of the talk, then that sends you down this complement pathway of I have a complement autoimmune disease, not some infection, cancer, or other autoimmune disease causing. Completely different. Completely different. Yeah. You can still have MPGN and C3, but you better know what the immunofluorescence says to help you distinguish from there. So MPGN is just an umbrella term. It catches everything, including C3. It's even lupus. Lupus is technically a MPGN, but we don't call it that because we have very unique ways we can diagnose lupus otherwise.
Those pathologists, they cause us some trouble.
So yeah, they do. So yeah, they do. And no, you're right. But that's it's a good segue. So all these schemas they're all obsolete eventually. Every good idea will be replaced by another good idea at some point, and we have to acknowledge that it's not going to be forever. I'm going to come back 10 years and give you a whole nother series of slides that just say this is the old way, and that's okay. I mean, that's kind of what we want, but it makes it very confusing when the pathologists are giving you a diagnosis based on a pattern they see on your kidney biopsy that tells you nothing about how it happened, why it happened, and what treatment can be given. It lends to nothing. So if you've ever heard certain diseases, they're named after some old guy who died 200 years ago, we really want to get away from that because it doesn't help you understand anything. It doesn't help you understand the why, the treatment, the mechanism of the injury. So it's important to distinguish C3G as a subtype of MPGN, because MPGN can be caused by almost anything between infection, autoimmune disease, cancer. All right. So I'll repeat myself because I think this is a complicated topic, and I may have lost you periodically. I may have lost you already. So that's okay. All right, so go back to this slide. So just appreciating that there's over 40 different types of proteins that have to interact eventually on just this alternative complement system. And that's just one protein interacts with another one, interacts with another one. And by the time they hit this, what's called amplification loop, all these proteins are turned on and just spewing out different inflammatory markers. And these inflammatory markers are C3A, C5a. This terminal complement does the damage to the walls of bacteria, but also the cells of your kidney. And then C3b, this protein here, often is binding to kidneys and causing some complications that I'll get into. So just appreciating that it may start with a single domino, but by the time you get to this amplification loop and no brakes have been applied, you get an amplification to all these other mediators of inflammation. So how did we figure this out?
Can you go back?
Yeah.
The alternative, the complement pathway.
Yeah.
In C3G, it impacts the kidney.
Yes.
But does it, I mean, is that just, does the complement pathway apply to other autoimmune diseases in general?
Yeah, so we have this, so complement is blowing up right now. It's everywhere. It's in vasculitis, it's in cancers, it's in infection. We have this sort of ongoing sort of tongue-in-cheek joke. If you look for complement, you'll find it somewhere, in some disease somewhere. So absolutely. It's a problem in cancers, it's a problem in infection, everywhere. C3G, specifically for kidneys, for reasons we don't fully understand, why is the kidney so special in being mediated by this injury? That's a harder question we don't know the answer to just yet. But the simplest thing I can tell you is, outside of the brain, the kidney needs the most blood supply and oxygen support. So it seems that if you have an injured or an inflammation, the kidney is going to be easily prone to that just because it soaks up so much blood and nutrients, and it's innocent bystander sometimes in this. Yeah. All right. So how do we discover this? So this is something Sanjay Sethi does a lot of and has contributed a lot to nephrology, not just C3, but others, performing laser dissection and mass spectrometry. So what this is pretty cool. So they take literally a laser, and they will cut out a portion of the kidney, this filter of the kidney in a biopsy, and they'll analyze it for different peptides and different proteins. And they'll estimate which kinds of proteins are dominant and which aren't. Are there a lot more protein of this or that? And it helps us understand really what proteins are there. And this is what you get. So it's not meant to explain anything to you other than just appreciate this is over here. These are all the different kinds of proteins that are found in the kidney of C3Gs. Just one after another, after another, after another, after another. And they're all unique, and they're all different. And these are all patients, 1 through 12.
And what would patient 13 who has no kidney disease look like? None of these would light up?
Some of them. You're always going to have probably a little bit of complement staining. So every kidney biopsy you do, maybe a little bit, maybe trace. If you look hard, it's always a little bit out there. Why is it causing a problem, and does it translate into inflammation? That's when it becomes a disease. But the point I'm making here by showing you this slide is that not one of these is identical. Not one of these patients has the same amount of complement proteins in their kidney as the other one. And this is just 12 patients. So this is specifically patients with C3GN or dense deposit disease, which is a distinguishing feature of just, again, going back to the kidney biopsy. But the point is that despite it being what we consider the same disease, you still get differences in the complement proteins when you perform this advanced method of protein detection.
So would patient 9 have the same outcome as the rest of the patient?
It's a wonderful question. We just don't know yet. The idea is that with some of these C3 inhibiting drugs that I'll get into later, we don't even make the distinction of C3 and MPGN necessarily, because maybe that doesn't matter. If you've made sure that you've ruled everything else out when it comes to infections and cancers and so on, and all you're left with is an MPGN with a lot of complement in there, maybe just inhibiting the complement will make the difference. So to your point, we haven't done very well, because the disease is so rare in part, to really differentiate which patients do worse on which end of the complement pathway they're on, or how much complement they have in one versus the other protein.
What are the numbers of green boxes?
those are probabilities. So the odds that that protein is there. So
Right. And so like people have the factor H and the factor I because you said that was a stopper.
yeah, that's a good. Well, at least in these patients, that's not a well-represented protein. So that's not the dominant one they found, most likely. Okay. So with these studies, what were they able to do? So what this what they used this method to do, the laser dissection and mass spec, was that they determined which kinds of, even going down to C3 breaks down into certain subcategories of the proteins. And the one inflammatory mediator I was telling you about was this C3b, and they call this the promiscuous protein. It goes everywhere and binds to everything and inflames everything it touches unless you have the proper breaks of your complement immune system to turn it off. And what this study found, in a way, was that this C3b is the thing in kidneys that is probably mediating the inflammation, at least on the filter. So once bound to the kidney, this C3b inflammatory mediator, you have to inactivate it. If you don't, it goes and progresses on for more inflammation and begets more information through that amplification loop. So without stopping this, the horse is fleeing out of the barn, and amplification of inflammation just progresses. So maybe this sticks to kidneys and causes inflammation, but why is this happening in the first place? So this is the sort of a modern way to talk about glomerular disease in general, but C3 specifically. So you've probably, if you've known someone or have glomerular disease, there's probably a conversation about, hey, your GN was triggered by an infection. And if you go back to think about the time that you had your glomerular disease diagnosed, I had just gotten a vaccine, or I just had an upper respiratory infection, or just something like that. So those things trigger complement. Those things trigger inflammation. Nephritic factors are circulating antibodies that disrupt this complement cascade. They interfere with the act of complement. They interfere with the normal processes to stop or start the inflammation. So in a way, like in lupus, if you make antibodies to yourself, that's an autoimmune disease. What if you made an antibody to your own immune system? That's C3G. That's complement-mediated disease. So if you have to kill the antibody or destroy the antibody that's targeting your own immune system. Yeah, I know. In circles, right? Nephritic factors are another thing. So cancers can sometimes make these. So the cancers itself can impact your immune system and inhibit its pathways. So these are all, and then lastly, mutations. So if you have a break to the system, if you have a cork to plug that constant drip, that's great. But what if you have a mutation in the gene that causes that break to be gone? And that is a lot of times what happens too for C3G.
That's
So
a lot of the times that happens.
the 1 in 10, 1 in 15. So depending on where you go. Okay. So let's talk a little bit about that nephritic factor that I was talking or alluded to. So let's say you have an antibody that you've created. You have an autoimmune disease. And in normal autoimmune disease, you create an antibody to your own tissues inappropriately. You should be making antibodies to viruses or bacteria. But if you make an antibody to your own immune system, what does it do? Well, these nephritic factors, they're circulating antibodies. They bind to the brake and break the brake. They disrupt the brake so that your own complement can go uninhibited and inflame your kidney in all the ways we'll talk about and that I have talked about. So you ruin the brake. That's one way, and actually a very common way. Like I said, what about genetic causes? So the genetic variants disable the brake. So if you're born with a mutation in one of these factors, you turn on your complement immune system because you got an infection, and there's nobody there to stop it, it perpetuates. So what are the odds of this? So this was a study just last year out of Iowa. About half to little over half people probably have a nephritic factor, one of those circulating antibodies that disrupts the normal order of things. The other, about 13%, depending on which country and which registry you look at, that can vary. but a minority of patients probably have a mutation in their complement pathway. And then unknown. This is the worst part, but for about half the patients, we just don't know why. We don't know why the disease progresses or was triggered at a certain point in your life. And we don't know, is that a kidney problem? Is that an autoimmune or immunologic problem? It's not clear. So how do we know? How do we know as clinicians what's driving this? So again, this is a lot of detail and a lot of numbers and jargon, but the point is there's a whole host of different lab tests, genetic tests, and markers we can assess to try and get a sense of how turned on is your complement system and at what points is it turned on the most. And if we can do that, then we can usually choose a therapy in which we can inhibit the immune system at the right place at the right time. The problem with this is all of these tests, all these specialized lab tests have to be carried out in a specialized lab. And this is only a handful of centers in the world that can really carry this out. We usually use Iowa as our center of excellence to perform these tests in a very rigorous way. But your local hospitals, they probably only do something like C3, C4 testing, and CH50. And those are just inadequate to really assess alternative complement. They don't really give you a full picture. These are usually expensive tests. They take time to turn around. They take time to come back. We don't do these every week or every month. You would be lucky if you do them every 6 months or so, depending on your therapy. You know, if you want to know if you respond to therapy, you repeat the test. You have to send all of this to Iowa, and it all comes with an expense. And these are not standardized routine tests that you can translate, well, Iowa did this and Cincinnati did that. It doesn't always work that way. So they all have different ranges of normal. So how does this knowledge help my doctor? So if you order these specialized tests and you get a sense of my C3 is this or that, my soluble membrane attack complex is this or that, how does that help me? Well, the best I can tell you is it may guide us in terms of your kidney survival if those numbers are low or high. And this is an example of a kidney survival, and that's the percent survival on the y-axis here, and this is time on the x. And depending on your levels of those markers can tell us reasonably how well your kidney might survive over the next 5 to 10 years. What are the other predictors of kidneys not surviving? Genetics. So rare genetic variants are usually the worst in terms of kidney survival. Having a low kidney function to start isn't good. And then having abnormal C3 or this SC5B9, which is the end of the cascade or end of the line of the complement activation pathway. All right. So if you have a diagnosis of C3, and you have abnormal biomarkers, meaning those C3 numbers, like I was saying, perhaps there's a driver of the complement dysregulation. Said another way, maybe one of those antibodies, the nephritic factors, is gumming up the system, or you have a genetic problem. And those are things you should know about, and that's why those people should get genetic testing or nephritic factor testing. You should send those lab tests to Iowa or Cincinnati or specialized lab. What if they're normal? Meaning, what if you have this diagnosis just because you have a kidney biopsy, you don't have any blood work that's abnormal other than kidney function and protein in the urine? We just don't know what's driving it at that point. And at that point, you should get genetic testing to help us understand. But even then, it's not really reassuring to us that if your labs are somewhat normal, your complement numbers are normal, does that mean you're out of the woods? Not necessarily. In fact, it becomes harder because we can't really monitor your disease if the lab tests aren't that abnormal. So between genetic testing, nephritic factors, and biomarkers, how does this help treatment? Why should I even do this? So this is where we get into the treatment. And the one take-home point I want you to know about the treatment right now, at this point, what you could go sort of pull off the shelf, is none of these therapies I have listed here, steroids, MMF, eculizumab, calcineurin inhibitors, or rituximab, which is probably the most common. None of those were created specifically for C3. None of them. They were not created, a lot of them weren't even created for nephrologists. Steroids for everything. Rituximab targets B cells, oncology made that one. Calcineurin inhibitors was originally invented for transplant, and eculizumab is used for something called AHUS, sort of a cousin of C3 glomerulopathy, but has never been studied well enough in C3G. And these all have different ways of affecting your immune system. So steroids are very nonspecific. They cover a lot of everything in your immune system, for good or bad. MMF, or mycophenolate, it targets the lymphocytes, or the antibody-making cells. Eculizumab targets complement. Sorry, this formatting is a little off. Calcineurin inhibitors are good for T cells or decreasing protein in the urine, but they don't do much directly for complement. Quite the opposite, actually, and sometimes they make it worse. Rituximab targets the B cells that make antibodies, but it's not been well studied. So this is data from the Mayo Clinic a few years ago. And what I want you to note about this is the amount of patients we're talking about is so small. So this is 10 years of the Mayo Clinic, going back to their biopsy registry, looking at all these patients. There was 24 patients that got MMF. There were 7 that got eculizumab, 7 that got calcineurin inhibitors, 2 that got rituximab, and 12 that got steroids. It's over 10 years. You cannot tell reasonably what works. And if you remember from one of the early slides I showed you, there was 9 patients with MPGN that got steroids. We're really not doing any better when it comes to knowing how many patients can respond to one therapy or another. We're still dealing with handfuls of patients. But the point here is that for now, we like to think that steroids and MMF are probably the best thing you could get for C3G. But according to Mayo Clinic, when they gave MMF, half of their patients, or over half of their patients, reached end-stage kidney disease. They were called NRs, or non-responders. A little bit more responded to monotherapy of corticosteroids, and hardly any responded to calcineurin inhibitors, eculizumab, or rituximab. So to put it simply, we don't know what we're doing. We don't have a good. These therapies are not it. They're not cutting it. And again, MMF is probably the one we use the most. There's a little bit more hope when it comes to when you combine corticosteroids and MMF. So this is data from Spain. Roughly a third of patients that got that cocktail. Again, this is 42 patients. They got corticosteroids and MMF. Roughly 36% of them had complete remission. But it was, again, very small numbers, and some of them had partials. However, patients with the genetic cause only achieve partial remission. So this does not fix a genetic problem. It's not meant to. Complete remissions were more common if you had the autoantibodies that disrupted the alternative complement, which is the nephritic factors. So if you can identify a patient with a nephritic factor and you can give them MMF, we like to think that maybe the MMF is targeting the cells that make those antibodies. But we don't honestly know that. And you might say, well, why wouldn't rituximab work? If that's targeting B cells that make antibodies, shouldn't that work? And we haven't even been able to show that easily. So it's really not even clear why that drug works. So current treatments, again, are not specific. They're not targeted. They're not designed or created for C3. In fact, we don't even completely understand how or why they work. And mostly this is because we have so few patients, and we can't really find their therapy. But that's about to change. So what's coming? So this is probably the most exciting thing we talk about when it comes to C3, and we're really in a golden era of treatment for glomerular disease and C3 especially. So first, I'll talk about just avacopan. So avacopan targets something called C5a and its receptor. This is a phase 2, but it's still pending. But there's a good reason to believe it decreases the progression histologically. Maybe not on the labs, but probably slows progression of the scarring in the kidney itself. And this should be published pretty soon. Pegcetacoplan is estimated phase 3 completion later this year. It's an injectable. It's currently not recruiting, but that targets what we like to think is the root of the problem. It targets that C3 convertase, or that C3 protein. And if you can target that, that's sort of the initial block for all that downstream nonsense I was trying to show you. So they're very, very promising phase 2 data and reducing protein, restoring complement numbers, and you really cut the head off the snake, so to speak. when you stop it this far upstream in the cascade. Iptacopan, this is estimated phase 3. It'll complete in 2026, most likely, is what they've estimated anyway. They've extended the age to 12 and 17 for enrollment. This is an oral pill, and it is recruiting. So this really is exciting for us because it's a pill, unlike eculizumab, which is every other week. You have to get an infusion, and it's not even that effective for C3. This will be a pill you can take home. Danicopan failed. It could not reach adequate blood levels. This targeted the factor D, which is a gas instead of a brake. This is the gas pedal, and if you could block the gas pedal, perhaps that would slow this down, but the drug level didn't reach adequate levels in the blood to do that. There are other versions of this, though, in the works. So what about diagnostics? We still biopsy. So to go full circle, and when I explained that you still need the kidney biopsy, you still need the pathologist and all their wisdom to describe a pattern of what they see, are we still left with that? And I think this is one of the cooler things in the last couple of years about diagnostics. So this was a non-invasive detection of inactivated C3b and C3d. Basically, what I want you to know that those are just C3 deposits in the kidney. And what they're able to do is this novel bioluminescent imaging probe. So they're able to bind these sort of antibodies to the kidney on the complement in the kidney of these mice, and it lights up. So in a sense, it's a way to scan someone, figure out what is lighting up in terms of complement in their kidneys, and give yourself a reasonable estimation of how much complement is there without doing something invasive like a kidney biopsy. Now, obviously, these are mice. These are not people, and we're kind of a ways away from trying this in people if it ever would work. But the point is this is kind of what's possible. This is what could happen in the future if you don't want a kidney biopsy, or you want to get a sense of how much complement is going on in your kidneys. Maybe we can give you an injection and scan you and see how much is there. So questions we're still asking, numerous. Should the cells that make the nephritic factors be targeted? So if it's an autoimmune disease and you're making antibodies to your own immune system, what if we killed the cells that make those antibodies? And that's a reasonable thought. And so some of the therapies they use in cancer to target cancer cells, plasma cells like myeloma, maybe we can use those for this disease. What new methods will be used to evaluate complement in kidneys? So this is a big question. If one drug doesn't work, how will we know the other one works? How will we go about trialing one after another? How will we properly assess the response? Are we still going to depend on protein in the urine and kidney function? We need those more advanced functional tests like the advanced labs you'd send to Iowa or Cincinnati or specialized labs. These drugs are going to be expensive. Is it going to be forever? Is it going to be lifelong? We still don't know the answer to that. Very possible. What about transplant? Can you get transplanted with MPGN and give this drug and feel safe that it's going to keep it at bay? We don't have clear information just yet. Can you get pregnant with C3? What is the outcome of pregnancies if you have ongoing C3 glomerulopathy? There's early data that it's okay, that it's not as traumatic as you might think for baby or mom, but these are ongoing questions we need to evaluate. So I know that was a lot. That was a lot of information and a lot of confusing information. It's very hard, actually, to explain this to other physicians, let alone if you haven't gone through 8 years of school. So I'm willing and happy to take questions, but I appreciate your attention.
Thank you. Yeah, as the layperson here, I thought you did a really great job explaining it, in layperson terms.
Thank you.
This is the best presentation on C3G that I've heard.
Thank you.
And second, Cleveland Clinic, I only have nice things to say. It was a wonderful hospital. My son and I went up there looking at the transplant team and everything. Phenomenal.
Thank you.
Team up there.
Wonderful. Thank you.
Yeah, so my question is more very basic. So when you're dripping faucet, why don't you take a wrench, right, and stop it, right? And I think what you're trying to say, one of those drugs is coming upstream to stop it.
You got it.
Okay.
You got it. Yeah, if you can, yeah, exactly. If you can plug the hole and stop it altogether, then that would be nice. The downside of that, and what a lot of nephrologists and physicians worry about, is we're talking about an ancient immune system, something you've had going back 600 million years. What happens if you just cut that arm out? Can you live without that for years and years and not get some devastating infection or some other consequence? I think it's probably overblown personally. I think a lot of other parts of the immune system will pick up the slack. But yeah, that's part of the deal. It's a rare disease, and we're not going to have a full appreciation of the safety of it probably for a while. But yeah, it's to your point. That's how you stop it. You plug it before it hits the water wheel. I don't really understand how better to explain this and making it simple. It's very hard. It's not even tangible. You've never thought about your immune system, let alone your complement immune system and what that even is. But yeah, it's just, best way to say, it's just a series of proteins that get amplified when you have an infection. And for reasons that I explained, just targets the kidney in the wrong time.
Well, it seems everything's connected with that immune system, all these diseases all over.
Yeah.
I was really hoping with COVID, with the whole world looking for a solution, would come up with here's the immune answer emails.
Yeah. So that's, it will be, we'll start targeting complement for IgA nephropathy, probably for membranous nephropathy. Don't throw out FSGS, that'll probably be up there too. I think we actually have an representation from pharmaceuticals. I think an ongoing problem we're going to have is, where do we stop? We're going to give this drug to a lot of people, hoping it helps, or these drugs that target complement. We're going to hand them out, I think, a lot more willingly than we realize right now, and we're going to repurpose them for a lot of different diseases, and that's good, but we got to be careful. All right, thank you.
No, I have a lot of questions. I'm just trying to decide which one.
Shoot.
It's like, do I subject these people to?
Yeah.
The amplification system,
Mm-hmm.
it applies to all three of the pathways.
It does.
And that amplification system is what, like the body knowing more about the invader and deciding, oh, it's this one, we're going to amplify it now and attack, like, no?
Yeah. So I'll go back to my.
Like, why? What's the amplification system? Because that's.
Yeah.
Or we could just slow it down.
So if you have, so C3, the protein starts up here, and it's constantly activated, at just a low level. But you have factor H and factor I that are always present, and they're the biggest breaks of the system. Factor B, factor D, sort of the gas of the system. They want you to get to the amplification loop. Once it hits the amplification loop, it turns that C3 protein into C3A and C3B. And those two proteins have different jobs. But one of the jobs of C3B is to feed back and bind to more C3 and make more. And so it's this just constant feed forward loop of you give it more protein for C3b, and it makes more C3a and C3b as a consequence. So C3 is one of the most abundant proteins in your blood. It's everywhere, all the time. And that's for good reason. You need constant surveillance in your bloodstream so you don't get an infection that runs wild. If you have this amplification loop and it turns all this hugely abundant C3 that's constantly floating in your system to these bad actors, C3a and C3b, that are inflammatory, and ultimately down to another amplification system called C5a convertase or C5 convertase. And you ultimately get literally blowing up of cell walls and disruption of cells. So you have these three components that are all working together to cause inflammation, depending on where this gets turned on. And if it's in the blood and this finds its way to the kidney, now you have C3b that's turning on this amplification loop in the kidney, and all this inflammation just in that one place. And the filter system is a delicate system. If you turn on the inflammation and you can't turn it off, and you have a kidney that has the second most largest blood supply of the body outside of the brain, you have a constant supply of C3 feeding the system over and over and over and over and over again. And until you cut the head off here and not down here or over there, then you won't win the game. You won't inhibit the inflammation. You have to do it upstream if you want to win the battle.
So just a question. I know you mentioned eculizumab as being used, and that's anti-C5. So can you kind of talk to the rationale why that would be considered if it's so downstream?
It shouldn't. You're exactly right. If this is bad and this is bad, and I give you a drug, and I'm going to say, all right, let's try this drug that only targets here, you're going to go, well, what about these guys? And I'm going to say, well, yeah, I don't know. And that's why the disease, that's why it doesn't respond to eculizumab, because these inflammatory mediators still do damage, and I haven't done anything to stop them. There are certain situations it helps. So if eculizumab is there and it inhibits the production of this guy, C5a, and then ultimately what we call terminal complement, those things do significant damage to kidneys. But maybe in a short stretch, you'll help the kidney. But over the long haul, these guys catch up with you.
Maybe, okay, if possible, could you talk about, like, so you said it's going to be blocking a large chunk of the immune system. Can you talk about some like the risks with that, with the infection risk?
Yeah. So, yeah, if you're gonna, we'll use eculizumab for an example. If you're going to block C5 convertase and then the production of these guys, these are critically important to destroy the cell wall of certain bacteria. So certain bacteria, in particular meningitis, the meningococcal bacterium, they have a thick cell wall. The main way we kill that in our own immune systems is by that mechanism. So if you decide to stop that, you have no way to protect yourself from meningitis and other bacteria that have a cell wall like that. So that's why we give these vaccines up front. You have to. If you're not stopping the production of this or this, and you just block the receptor, like Avacopan, then you don't. Then you don't need to worry so much about meningitis infections. Or even up here, you haven't just, this is killing me. You haven't disrupted those pathways, and so maybe your infection risk isn't quite as high. So I don't think we really understand perfectly who should be vaccinated against what and who, but it just theoretically it would make sense. If you're going to disrupt cell wall lysis and certain bacteria, that's how they're destroyed, you may want to vaccinate yourself against those things. But I think it remains to be seen. And we use a lot of this because of people that were, genetically born with certain disruptions in their complement, what kind of infections they get. But I think over time we'll understand who gets what infections and why, and should we protect them a little bit more, a little bit less. I don't think we totally understand.
So I have one more question. If you go to the beginning where you have the one with filters, why can't, is somebody looking at making like regenerating filters? So if this thing keeps burning out, is there a way to regenerate?
Yeah. So the best way to get new filters is to take someone else's by transplant. Once the filter is gone, you can't regenerate it, and that's for good reason. The body actually does try to regenerate some of that, and I can't show you, I don't have the slide, but that's part of where MPGN gets its name. So the membranoproliferative, part of what the pathologist will describe is something called double contouring. So they'll see the filter on the kidney, and then the kidney's tried to duplicate that filter over top of it as a mechanism to wall off the inflammation and make a new filter. But that ends up being injurious. That is a bad idea for kidneys in the long run.
That's the scarring?
That's the scarring. So it tries to protect itself, but it's a negative consequence in the long run. But, yeah. Good question.
Thank you.
This is a really question. I just want to send a little gratitude your way for actually focusing on this. because I think there are very few of you who can understand such a complicated form of this rare kidney disease, and so I know that it is such a rare disease, and there are not as many out there who are actually studying it. So I should.
Well, thank you.
Yeah, that's a good question. Why are you?
I could be no. I can.
Yeah, you're like the best.
Thank you.
Is it just
I don't know.
intriguing to you?
Yeah, I guess so. I
need to just like replicate.
I like the challenge, I guess. I don't know. It always just kind of made sense to me, and but yeah, in truth, I think if I hadn't met a few C3 patients, I probably wouldn't feel that intrigued by it. But one of the first patients I ever met in Jan Clinic had C3, and I felt so bad because nobody understood what she had. Nephrologists didn't even understand how best to explain it. And it's like, oh, what about your patient advocacy group? And she's like, oh, what, the other 5 people that have this disease? Like, great, thanks. So I felt like, if nothing else, I should be the one that should understand it best for her. And that was so.
Well, I applaud you for doing that.
Thank you.
I have a follow-up to that, actually. You mentioned that you send those, or you do all the testing with Iowa, and I'm surprised that Cleveland doesn't do that in-house. So is everybody in the United States sending their stuff to Iowa?
Pretty much. Yeah.
Okay.
This is not a plug necessarily for Iowa. I love them. Carla Nestor, I lean on her so much for answers, but it really is a lot of work, and it's a very specialized way to carry out lab tests that, it would take a lot of effort, I think, and a lot of personnel to build a lab like that. And I honestly don't even know the first place to start. But the implication of that is pretty significant too, because if we all have to do something like send labs to 1 or 2 places, Mayo or Iowa or Cincinnati or something, what does that mean for patients as we identify more? How are we going to, we can't just all send blood to Iowa. I mean, we got to be able to do something on our own. So I think a lot of what you may see in the future is some of these specialized centers or quaternary care facilities are going to do more things like the mass spec that I showed you, just giving you complement profiles, maybe periodically sending 1 or 2 tests. But really what we want to know is if we give you a drug, how do we know it's doing the thing we intended for it to do? And we have to check certain labs to make sure that's true. So just to give you a scary thought. So let's say you have just one. If you have a disease in which we have to use eculizumab, which blocks some of that, there are some people that have certain mutations where that drug doesn't work. And we really don't know that very well unless we do some of these more specialized complement tests. And otherwise, if we don't, now I'm giving you a $20,000 a month drug for the rest of your life, or the rest of your kidney's life, and I just don't know. So that's what keeps me up at night, is I'm going to give you a drug that's that expensive, that's that potentially harmful. If in the wrong hands, I got to know it's working, and I got to know before protein and creatinine change. That's the end of the game.
And you can only measure that with the biomarker testing. You can't do that with the genetic test?
It's all got to work together. So I have to measure, is complement working? Where is complement working? Genetically speaking, what are you working with? Which antibodies are floating around?
Another question. I know you were walking at the beginning with the change in classification now, and kind of how we're talking about this. Is this like fully adopted? Do you think across country, or are there still kind of practices that use the original classification system? Like how's that adoption?
Yeah, it was 2013 where there was a collection, a meeting, a congress of patients or of providers, specialists in C3, and a consensus was reached. But you're still going to find pathologists out there that will give you a pattern. They'll say membranoproliferative pattern. And the same goes actually for lupus even. They'll just say immune complexes deposited in kidney. Take with that what you will. So it is probably not universally true, even to this day. But there's a lot of caveats when you're making a C3 diagnosis. So there's something called infection-related glomerulonephritis or post-infectious GN. And that it can mimic C3 on a biopsy if you don't know what you're looking and why you're looking. Certain times the stains don't fully reflect what's going on, and you need to do a different kind of stain. So, yeah, it's not straightforward, and that's kind of the problem. Is we're kind of in the dark ages in terms of kidney biopsy and using it to assess complement.
I know you guys might have more questions, but we're going to kind of wrap it up because we're at time, so I apologize. But if we could get a round of applause for Dr. Cavanaugh. Thank you so much.
Thank you.